superficial radial nerve with the handcuff palsy. But it is a cutaneous nerve, so is it likely to have any motor branches? No. So our diagnosis with this here is burning sensation on the lateral thigh, or a lateral femoral cutaneous nerve where that goes, without any motor weakness. So you go test their hip flexion and quadriceps and all these muscles, and they're all healthy and strong. When we see this, so our lateral femoral cutaneous nerve coming off of 2 and 3 right here, we see compression at the inguinal ligament, and it rubs up against it because you have too tight of a belt on, or you're a police officer and it weighs a lot, or you got pregnant and you're still wearing the same pants. That compression occurs over and over again. If we rub two structures together over and over again, what happens? Friction, it gets hot, so you get burning. The majority, over 90% of these patients complain of burning sensation on the lateral thigh. So it's just a hallmark, classic thing that we look for with that. Common peroneal nerve. So what nerve branches into the common peroneal nerve? Sciatic, yeah, sciatic goes to tibial and common peroneal nerve. What two things give us motor symptoms? What two nerves give motor symptoms before sensory? Yeah, foot drop and wrist drop. So foot drop could be caused, most commonly caused by the common peroneal nerve, and we see it most commonly from an ankle injury, weirdly enough. So classically, we look at someone falling or jumping, like a rebound in basketball, they land on their lateral ankle, and then they have a fracture of their fibular head. That fracture causes foot drop. Yes, yeah, exactly. So it's just talking about the common fibular nerve there. But you could also compress it, which these were listed as the 3 most common things, which would be crossing your legs. So if you have lost a lot of weight and you weren't able to cross your legs, and now you start to compress that region, or I should say separate that region, it's a very common reason for that. So if someone has this, that would be a good first question. So trauma that we just looked at, and then tight stockings. Whenever it says stockings, you know it's very, very old. But when people used to wear soccer socks or rugby socks just to go out in public. Okay, so we get L5 gives us our innervation to our anterior compartment of the leg. So it gives us our ability to walk on our heels or dorsiflex. So this is our classic differentiator with foot drop as far as the nerve goes. S1 is plantar flexion, giving us the ability to walk on our toes because it goes to our tibial nerve. Alright, diabetic neuropathy. So here's our glove and stocking presentation once again. So we can see the initial presentation of diabetic neuropathy is you get numbness and tingling in your toes and potentially fingertips, usually toes first, and then it makes its way up. Classically, when it makes its way up, it gets to like the ankle, then you start feeling it in your fingertips. But everyone's a little bit different. But with this, we just note that this is this ascending. So the stocking glove presentation, if you ever hear that talking about diabetic neuropathy. But as time goes on, it usually becomes a lot more painful. So numbness and tingling, it's annoying, it's uncomfortable, and as it gets worse, now it's horribly painful. It can affect a lot of other things, as you guys know. The differentiator for just about every condition under the sun is diabetes, unfortunately. And then alcoholic neuropathy. So same exact presentation, but alcoholic neuropathy obviously caused by alcohol instead of blood sugar issues. And obviously more likely to have it as a chronic alcoholic. But some people are just more prone to it, so even though they drink a lot less, they're not able to detoxify as well. But we want to note that our B vitamins are very, very important. So the one thing that you can do if they're going to continue to drink is give them methylated B vitamins, and they can actually absorb them. But alcoholic neuropathy is horribly painful. The majority of them have extreme amounts of pain with this. But polyneuropathy, it's the same presentation. It's ascending, just like diabetic neuropathy. All right, Guillain-Barré. So Guillain-Barré is one of the 6 classic neuropathologies. You guys will all see this on boards. It will here. I promise you, it always does. But Guillain-Barré syndrome is an ascending motor polyneuropathy. So a rapidly progressive symmetric ascending motor polyneuropathy. So you have a post-viral infection classically, and a week later you can't move your toes, and then a few days later you're in a wheelchair, and then a few days later you're struggling to breathe because it hit your phrenic nerve, and you cannot breathe anymore. So that's the big fear. These people recover very, very well as long as it doesn't hit their phrenic nerve. If it does, then they obviously need to get a ventilator so they can breathe. But a post-viral infection, where you see this more common with people with autoimmune conditions. All right, last one here. Charcot-Marie-Tooth. Yeah, question?
This one who was just doing, since it's post-viral, is there no like nerve root origin towards this one?
A nerve root?
So like, you know how like some of the other ones, it's like you compress the radius nerve.
Oh, yeah.
Is there like, it's not one of this because it's a post-viral infection?
Yeah, absolutely. It's immune-mediated response that ends up causing the polyneuropathy. But the first thing you would notice is the areflexia, so the lack of no reflexes at the Achilles, so the lowest portion there. All right, last one is Charcot-Marie-Tooth disease. So Charcot-Marie-Tooth disease, you get these classic presentations of muscle wasting in the lower extremities, so the calves, and then the bottom of the feet. You see this pes cavus presentation, which is just the cave-like presentation on the bottom of the foot. They have super high arches because the muscle wasting we see specifically on the bottom of the foot to allow for that proper arch just isn't there, so we get an excess of an arch there. But degeneration of specific muscles in your feet is mostly motor. We don't see that much sensory issues here, but the pes cavus, the hammer toes, the toes going up like this, you can see the hip joint in dorsiflexion there. But you notice this young, so they're usually 10 to 15 years old where this presentation starts to come in. So where you would expect them to start developing muscle like they do in the rest of their body, they just don't, and then they get this odd presentation with it. Yes?
So at one point they had like a appropriate level of muscle mass for a 10 to 15-year-old, and then it started to bursts, or
Yeah, it usually,
always small and it never grew?
yes, but it's usually with the puberty, it's where you start to develop more of that muscle mass. It just becomes very, very obvious. And this is, the hammer toes and the pes cavus are like the extreme aspects, and then you look at their calf and it's pretty hollowed out. It's surprisingly more common of a condition than you would think. But once again, from the nerves degenerating, so it's a lower motor neuron condition, like all of these that we've been looking at, so we're looking for atrophy and weakness associated with it. Alright, I'm going to put on attendance.